Good afternoon. Welcome to our webinar, Case Studies in Bioidentical Hormone Replacement, Working with Men. I'm Dr. Pushpa Larson. I'm one of the consulting physicians here at Meridian Valley Laboratories, and it's my pleasure today to introduce your two speakers, Dr. David Zeoli and Dr. Barry Wheeler. I'm actually going to do Dr. Barry Wheeler first. He's doing the first part of the webinar and then some at the end. Dr. Wheeler is a graduate of National College of Naturopathic Medicine, and he joined Meridian Valley Laboratory in February of this year, where he works as the marketing director and also is involved in some of the research here. He's doing research currently on the effects of creatine on DHT and 3-beta-adiol levels, and he's also done research on medicinal plants in the Amazon rainforest and assisted in studies on vitamin C at the Linus Pauling Institute at Oregon State University. Dr. David Zeoli is also a graduate of NCNM, and he's licensed as a naturopathic physician and also as an acupuncturist, and has a doctorate of Oriental medicine. He's in active practice at the Tahoma Clinic, where he consults regularly with Dr. Wright in the area of bioidentical hormone replacement and actually many other aspects of functional medicine. In addition to getting his Master of Science in Oriental Medicine, he also had advanced training in acupuncture, facial rejuvenation, energy healing, Kitasi, Qigong, and the use of traditional Chinese herbal formulas. During his years of practice, he's also published a number of articles advocating a nutritional approach to the prevention and treatment of disease. And he has a lot of experience with working with patients with bioidentical hormones here at the Tahoma Clinic. So I'm going to turn it over to Dr. Wheeler now, and enjoy the webinar. Oh, one last thing. We will be taking questions during the webinar as they show up to the degree that we have time. So if you have a question, just type it in, and as we see the questions and as we have time for them, Dr. Wheeler and Dr. Zeoli will be answering them. Okay, thank you. Dr. Wheeler?
Oh, thank you, Dr. Larson. So, go ahead and get started here. This is just showing you kind of an overview of how hormones are metabolized. So, cholesterol is important to produce hormones. Androstenedione that you see right here is the prohormone to testosterone and estrone, and we can measure that in testosterone serum metabolite profile. Low levels of androstenedione make us more likely that there's going to be greater production of estrogens when testosterone is supplemented. I'm sorry, elevated levels of androstenedione. Elevated levels of androstenedione make us more concerned about aromatization to estrogens when testosterone is supplemented. And then testosterone is there, so 5-alpha DHT being the most potent androgen right here. Progesterone is metabolized to pregnadiol, and that is the metabolite we measure in urine to give us a measurement of 24-hour urine, 24-hour production of progesterone. And then cortisol is metabolized, and we can add up some of these metabolites to get an idea of 24-hour cortisol production. Cortisone is the storage form of cortisol, and low cortisone would make us less likely to want to prescribe licorice. Should be a contraindication, and it will help us evaluate where they are in terms of adrenal fatigue. Aldosterone over here is low levels of aldosterone are related to age-related hearing loss, and you can actually supplement aldosterone as well. So I'd like to thank Dr. Wright for allowing me to use some of his information from some of his slides. his philosophy is to copy nature. And here's a quote from Paracelsus: "The physician is only the servant of nature, not her master. Therefore, it behooves medicine to follow the will of nature." So we get this question sometimes: aren't menopause and andropause natural? Well, the flip side is that death and dying could also be considered natural sooner or later. So we would like to delay those as well, just like many of us would like to also delay menopause and andropause, or not have it happen at all. So what are the benefits versus risks of bioidentical hormone replacement? For men, there are a number of hormones that we can replace. The main one most frequently sought after is by men is testosterone, but other hormones definitely play their part. So the risks are not entirely known yet. Evidence is still growing. There could be a small chance of increased hormone-related risk. In younger individuals with higher endogenous hormone levels, they may have an increased cancer risk. And I'm going to talk about how to measure and reduce those risks as best we can as well in this presentation. But with testosterone replacement for men, we see decreased Alzheimer's disease, basically keeping testosterone within normal limits, adequate levels of testosterone, improved cognitive function, decreased cardiovascular disease, decreased osteoporosis. In women, this is about non-smoking women, estrogen replacement with bioidentical hormones decreases COPD. And I will have some of these citations. Some of these citations should be posted on our website here below this presentation. So, but with the concept of copy nature, we also want to use nature's route of administration. And so the closest to natural is the transmucosal. Transmucosal means, for men, the perianal mucosa. And basically, we want to get the dose as concentrated in a cream as we can so that we'll have the greatest amount of absorption, and as well as not making a mess in our pants, but also it gets it closest to the testicles where the testosterone is naturally produced. Transdermal, you could apply it to the scrotum. Some men will apply it to the arms, but the scrotum is the next closest to natural. And so again, we want to copy nature's timing, and for women that would be a monthly cycle, and for testosterone and adrenal and thyroid hormones, it's a daily. There's a rise and a fall daily. And then for melatonin, it's nightly, along with growth hormone as well. So what about oral? Is it natural, customary, and practical? Well, it's just really easy, right? You just pop a pill and you're good. But no, you're not, because there's actually evidence showing it increases liver cancer risk. So that definitely oral testosterone or any oral hormones, with the exception of progesterone, probably not a good idea. Maybe, mainly the estrogens and testosterone. You just want to avoid those with oral. There's a lot of hormones out there, so I don't want to, mention them all right now. But injected for testosterone is the timing is off, because you're injecting it. You have to inject you get a spike and then a kind of a drop, basically. So you have to inject a really large amount so that once the spike is done, there's still adequate testosterone around to get the benefits. But the risks of that spike are probably, they're probably too much. So, especially since there's other ways to administer the testosterone. Subcutaneous is very, along with injected, they're both very convenient, but the timing is way off, and oral too. But the timing for subcutaneous is way off, because it's a constant flow. There's no rise and fall like we have naturally during the day. And if you get the dose wrong, you're stuck with it for 3 months. So there's some problems with that. And this is about estradiol, estriol, and progesterone, but it's basically a review that Dr. Kent Holtorf did. Thank you, Dr. Holtorf. and it was published in Postgraduate Medicine, Volume 121, Issue 1, in 2009, kind of comparing, the data and physiological data, to quote, and clinical outcomes demonstrate that bioidentical hormones are associated with lower risks, including the risk of breast cancer and cardiovascular disease, and are more efficacious than their synthetic and animal-derived counterparts. Until evidence is found to the contrary, bioidentical hormones remain the preferred method of HRT. So, it's from Dr. Holtorf. Of course, we want to do as much testing as we can to ensure safety and keep things within physiologic levels. And we can do, so in this, for hormones, we test their metabolites as well, and there's a lot of reasons to do that. And we'll talk about those. But in terms of symptoms, your patient may present with declining libido, memory problems, lack of enthusiasm, loss of strength, grumpiness. They may not have any symptoms, but they're interested in, quote, anti-aging. We call it healthy aging because aging is natural, but we want to age healthfully. And prostate examination is, you may see an enlarged prostate, BPH. You definitely want to rule out any chances of prostate cancer as best you can before administering testosterone. So on initial evaluation, we will do a DRE, or they'll come to us already having a DRE been done, and we'll measure testosterone, free testosterone, and serum. This is just basically, these are the cheapest tests, the lowest cost to the patient. And also PSA and percent free PSA, because if it's not elevated, we want to make sure it doesn't elevate with our follow-up testing, right? And if they can afford it, we usually will do a 24-hour urine hormone test as well, and perhaps a testosterone metabolites profile. So there are ways to stimulate the production of testosterone if it's low endogenously, and these include tribulus, zinc, vitamin A, that's vitamin A picolinate, and boron, Vitex. Zinc, by the way, is a 5-alpha reductase inhibitor, and also there's some research showing that it decreases prostate cancer risk. So, and most people are deficient in zinc because our soil, unfortunately, has become so depleted. Vitex will stimulate the production of LH, which causes, and LH stimulates the production of testosterone in the testes. HCG is actually very similar to, will activate the same receptors that LH can activate, and that's probably how this is working. So if you check your patient for low LH, especially if they have a history of undescended testes, you check them and they have a low LH, you can try HCG to stimulate the testosterone production endogenously. And Dr. Wright usually does 500 IU every other day. And sometimes this works, sometimes this doesn't. And it also can increase human growth hormone. So testosterone and human growth hormone are two hormones you can see on a 24-hour urine hormone test. And as you probably know, human growth hormone is like melatonin. It's produced at night, so it's it's a pretty hard one to measure. But a 24-hour urine hormone profile gives you a decent idea of how effective your treatment is being. So this one works better in younger men. It's cell therapy, kind of similar to some of the standard process products, and basically it's live cells. Similar concept to stem cell therapy as well. And these are injected, and it can be quite expensive and hard to find, but it is an option as well that you might want to consider in younger men. And then there's Detox, very naturopathic, holistic approach. And one of the added benefits of Detox using infrared is it also increases nitric oxide. So nitric oxide is kind of the limiting factor for erectile function. Testosterone can be effective as well, but if there is no nitric oxide, it's hard for those blood vessels to dilate, right? And one test you can do that will be available next month to see how effective, how important nitric oxide may be is urine nitrite level. There's a study done where people with low urine nitrite levels and erectile dysfunction received 1.67 grams arginine TID, and it was, if the urine nitrite levels were low, that was a very effective treatment. Not so much if the urine nitrite levels were very low. So it can be a helpful, guide to determine if you want to go down that path. Nitric oxide has a lot of other benefits, cardiovascular as well. But in terms of safety, you also want to watch out if they have a history of herpes simplex virus. You would, it may be contraindicated, or you would also supplement lysine at the same time, equal or greater dose of lysine. So exogenous replacement, Dr. Wright usually starts out 50 to 100 milligrams daily, based on what he sees on the testosterone, free testosterone serum, and 24-hour urine hormone profiles. And this is applied to it's actually the perianal mucosa, or the scrotal skin, and no oral, so no oral testosterone. And if free testosterone is just low, total testosterone is okay. It could be that it's all bound up to sex hormone binding globulin, well, most likely bound up to sex hormone binding globulin and albumin, so you could do a nettle-pygeum complex, and the pygeum's healthy for the prostate, and then the nettle, this is Urtica dioica, I hope I said that right, 3 capsules BID, and you want to use the root of the nettle plant, and that will help displace the testosterone from sex hormone binding globulin, and then you can repeat the free testosterone test in a couple, 2-3 months to see how effective that is being. Your patient should report, an improvement though. At 2 months, you're going to want to do the follow-up, check the PSA, the testosterone levels. The HAAH is a cancer marker that you can also test as well. It's not specific to prostate, but just overall cancer. So if that's elevated, you want to kind of start looking around, seeing what's going on with that. If the PSA, we'll talk more about what to do if the PSA is rising as well. And so then on your 24-hour test, you also do that at 2 months, and you're going to get to see all the estrogens, the 2:16 ratio. There's research showing that is a helpful cancer marker to men. You want to keep that, from being too low. And you also get the DHEA and testosterone metabolites, but you're not going to get all of the important testosterone metabolites like the 3-beta-adiol, and that's the 3-beta-adiol. So you'll want to do that at 3 months to make sure that DHT is, being balanced by 3-beta-adiol. I'll show you some more, some profiles on that and more information on that in a bit here. Transdermal, the reason we go with perianal mucosa is because with the skin we can have a few different problems, one of them being transdermal fatigue, and this is where we get poor absorption, so we're not getting the results that we're looking for, and this can happen right away, or it could take a bit. And there's some different causes to this. You might need to change the base. You definitely want to keep, do follow-up testing on a regular basis to make sure and see what's going on. Make sure it's getting in there. And then the treatment is to switch to perianal mucosa, or the solution, I should say. And you're going to see this best on a 24-hour urine hormone test because you're going to get all of the estrogens and their metabolites. Oh, I'm sorry, this is with hyper-aromatization. You're going to see this best on a 24-hour urine hormone test. And Dr. Zeoli will talk more about this with some cases, but the cause is usually glucose intolerance. So you can do a glucose tolerance insulin resistance test, and yeah, usually this is the problem. So the long-term solution is to fix their diet and exercise, and give them and supplements to to reduce insulin resistance. That will fix the hyper-aromatization. But in the shorter term, we'll give things like myomin or chrysin And Myomin can be taken orally, and chrysin sublingually or topically. Apex has a product, Testanex, and there's other products out there like the and Chi Enterprises makes a really good aromatase inhibitor, Myomin. It's natural, and then there's also melatonin, which may be helpful with hyper-aromatization. So that's what's in Myomin. And then we have 5-alpha reductase. So 5-alpha reductase is the enzyme that converts testosterone to DHT, to 5-alpha DHT. And 5-alpha DHT being 4 times as potent as testosterone, we can get a lot of benefits, but there's also some risks. We want to keep that within physiologic range and monitor that. And some natural inhibitors of 5-alpha reductase. So if there's too much DHT and they're getting problems with hair loss or BPH, you can try Zinc and GLA, BID, TID. If that's insufficient, you could consider saw palmetto and some other supplements. Of course, you want to watch out for over-inhibition of 5-alpha reductase, and because that's going to, if we shut down the production of DHT too much, we also decrease 3-beta-adiol, which is an androstenediol, and that's androstenediol is an androgen that behaves like an estrogen, and it activates estrogen receptor beta. There's a citation down there, estrogen receptor beta in prostate cancer, and that's so there's definitely a fair amount of research out there showing that we want to do this. We want to keep DHT within a healthy range, but not over-inhibit it. And a lot of this began with the prostate cancer prevention trial, and this is where 18,000 men had a PSA less than 3 at the start, and they treated them for 7 years with either finasteride or placebo. I guess that's not really a treatment, but they received placebo, and the ones who received finasteride had 613 aggressive prostate cancers, whereas the ones who received placebo, 490 aggressive prostate cancers. So the finasteride group had overall less cancers, but if they did get cancer, it was more aggressive. And a lot of researchers believe that the cause of that was that they shut down DHT production so much that it shut down the production of 3-beta-adiol, and since 3-beta-adiol has anti-cancer effects through the estrogen receptor beta, we don't want to over-inhibit 5-alpha reductase. So a Cochrane review basically said that 5-alpha reductase inhibitors, there's not enough evidence that they decrease mortality. So here's what's going on with testosterone. It gets converted to 5-alpha reductase, or to dihydrotestosterone via 5-alpha reductase, and so testosterone and DHT activate androgen receptors and cause proliferation and secretion. Well, DHT, being very potent, is converted by our bodies to 3-beta androstenediol via 3-beta HSD. HSD is hydroxysteroid dehydrogenase, and 3-beta androstenediol, also known as 3-beta-adiol or 5-alpha androsten 3-beta 17-beta diol, causes differentiation of tissues. So differentiation, is the opposite of what happens in cancer, where there's dedifferentiation. So 3-beta androstenediol is considered to be more protective to the prostate. So in a urine profile, you're going to see 5-alpha reductase inhibition when they're on a 5-alpha reductase inhibitor. And Dr. Wright saw this profile, and he was like, this is over-inhibition. So the patient went off Avodart, and then their 5-alpha reductase went back to kind of midline. And so if the patient has a rising PSA, you're going to want to try to reduce it before referral, basically, as best you can. And so you do repeat PSA testing. And here's some of the supplements that can be effective. I'm not familiar with peanuts, but I guess Dr. Wright has used that one before. And the reasons that you want to try to handle the PSA as best you can before referral is that a needle biopsy may spread cancer cells along insertion and withdrawal tract. But definitely if you can't get the PSA to reduce, you're going to want to do, or if there's an abnormal DRE, you're going to want to do a color Doppler or magnetic resonance imaging to kind of before you go to the needle biopsy step. Testosterone for Life is a great book. It's written by Abraham Morgentaler, kind of just dispelling some of the myths around testosterone. There's definitely multiple sides to it, but he's from Harvard, so it must be okay, right? Dr. Wright, by the way, also attended Harvard for undergraduate, so you know, I find Harvard's a pretty good school, they say. And here we have some cases. Dr. Zeoli is going to talk about these.
Hello, this is Dr. David Zeoli. I'm a practitioner here at the Tahoma Clinic. So we're going to go over some cases. First one here is Thomas. But first, let's show you the Comprehensive Plus Hormone Profile. This is the 24-hour urine collection, and it gives all kinds of important data on all the different hormones and the metabolites. You get all your estrogen, estrone, estradiol, estriol, the phase 1 metabolites, phase 2 metabolites. You also get your androgens. You get progesterone, adrenal profile, mineral corticoids. You get your HGH, your thyroid. You also get the 5-alpha reductase enzyme activity and the 11-beta hydroxysteroid dehydrogenase activity, which interconverts cortisol and cortisone. So that's a quick overview of the hormone panel. For our purposes here, we're just going to focus on the estrogens and the testosterone. So the way we use this test, typically when a gentleman comes into the clinic with symptoms of low testosterone level, and that's a long list, but usually it includes some sort of a decreased libido, decreased sexual functioning, has a loss of muscle mass, decreased stamina, loss of strength, fatigue, depression. There's more things, but those are the ones we hear a lot over and over again. So the first thing we do here at the clinic, as Dr. Willer mentioned previously, we check their LH, we check their total testosterone, their free testosterone. Also, we get a baseline reading for the PSA. We do both the total PSA and the free PSA. After that, we perform full examination. Oftentimes, we'll also do a chem screen and a CBC, find out if any other underlying problems are present. And if everything looks okay, and it's appropriate, we'll give them a prescription for testosterone. Usually for the younger folks, we'll try to increase their endogenous production with the methods that were mentioned previously with different vitamins and different herbs. If they're older, we'll go right to the testosterone cream because there's less of a chance they'll be able to produce their own naturally. So one parameter that we check on the urine profile is the testosterone to estrogen ratio. You want to have about 4 times as much testosterone as estrogen. And that'll become more clear as we go over some of these case histories and some of these urine test results. So when the ratio is high, above 4, that indicates some degree of over-aromatization or hyper-aromatization. When it's greater than 4, that's what you're looking for. That's desirable, that they have more testosterone than estrogen. So here's one case. This is a 67-year-old man. He presented to the clinic with symptoms of low androgens, low testosterone. Usually, as I mentioned, we do the serum test first, but in this particular instance, a urine test was done. And we can see quite clearly on this urine test, his testosterone is very low, 3.1, reference range 20 to 200, whereas the total estrogens are in the reference range, 22.6. So this gentleman has more estrogen than testosterone. So this is a situation that he wanted to correct and do something about. So definitely he was a candidate, because he was a little bit older adult, he was a candidate for the Bioidentical Hormone Replacement Therapy, the testosterone cream, which is what he received. So here's a second case, Michael. This is a 62-year-old gentleman, and again, he came into the clinic with complaints of low testosterone. We went through the complete evaluation with the serum test. His serum testosterone was low, and his PSA was in normal range. And he was amenable to taking the testosterone cream every day. And after about a month or 2, we ran this urine profile, and this is the result we got for the testosterone and the estrogen. His total testosterone is 115.9, which is well in the reference range, above median, which is important to note. total estrogen 18, which is right about median, which brings the total testosterone estrogen quotient or testosterone ratio to 6.44, which is above the 4, which is what we like to see. So this is the ideal case. This is when everything goes right, which is most of the time. Most of the time you'll see this. They come in with symptoms. They go through the evaluation and the testing procedure. They get the testosterone prescription and they use it and everything gets better. All the symptoms disappear, feels 10, 20 years younger. And then later on down the road, you do the 24-hour urine test and everything looks good. So this is what you like to see. Third case, Joseph. So in this particular instance, this is when we're starting to see some hyper-aromatization. You see the testosterone is 101.8 and the total estrogen is 30.4. So this gentleman is a similar case to the previous one. He came in with symptoms of low testosterone, went through the entire evaluation, got the serum testosterone reading, which was low, received his testosterone prescription and started taking it, and then did this urine test and found that his estrogen was higher than we were hoping to see. In this particular instance, he didn't get any good results from the testosterone. And I'm not sure if that's a coincidence or just an individual case. But the testosterone didn't work for him. His estrogen was high. So the thing to address would be to help to decrease the hyperaromatization by addressing the insulin resistance that Dr. Whaler talked about before. When you really treat the insulin resistance, it'll help the body naturally stop hyperaromatizing. So it'll increase the testosterone level and decrease the estrogen level. And of course, in the meantime, while they're addressing their diet and their lifestyle and exercise, they can take those supplements, myomin and chrysin, to help to decrease the hyperaromatization. So this fourth case, Robert, this one's a little bit different. So there's a few things going on here. You see that estrogens are high and also the testosterone is high. And there's a couple of possible explanations for this. Again, this gentleman is taking 50 milligram of testosterone per day after the evaluation and initial serum testing. And in this case, it did work. He got some benefits from it. But let's pretend we don't know that. Let's pretend we just have this test result in front of us and we're not sure if it's working or not. So let's say that testosterone is 225. That could be just from a high dose of testosterone. He's taking too much. Another possibility is that he's hyper-excreting the testosterone. This is what happens when you use the testosterone bioidentical cream and it goes straight to the liver and then comes out in the urine without having any beneficial effects. So when you see a urine test like this, the first thing you want to do is check the serum over again to compare with the urine. If the serum level is low and the urine level is high for the testosterone, then you suspect that it's getting hyper-excreted, that it's going out into the urine without actually doing anything, in which case the treatment would be cobalt. This is a treatment from Dr. Wright, and he prescribes 500 to 750 micrograms per day of cobalt chloride, which can be obtained from our Tahoma dispensary. And within a few weeks, it'll increase the serum testosterone while lowering the urine testosterone. So that's another possibility in this case, that it's hyper-excreting. But one thing we're definitely seeing is high estrogen levels. So there is some degree of hyper-aromatization, and that needs to be addressed by addressing the underlying insulin resistance. Case 5, Ray. So this was a younger gentleman who was over-enthusiastic about taking his testosterone supplementation, and it turns out he was hyperaromatizing. So you see a very high estrogen level here, 48.4. It's almost half as much as the testosterone level. So this is a case where you want to do something immediately. You don't want to let this sit for too long. You risk growing breasts in the guy, gynecomastia. Also, there's an increase of prostate cancer with these high estrogen levels, not to mention other possible deleterious side effects. Okay, the next case, Tom. Now, this gentleman he was a younger gentleman, and he had a particular characteristic. He was a recovering alcoholic and a recovering drug abuser. And we see in people that abuse the drugs and the alcohol that the testosterone is much lower than you would expect for their age group. In this case, he's in his 40s, and his testosterone was only 4.5, and his estrogen was 13.9. So his estrogen was 3 times higher than his testosterone. Now, sometimes with people that are recovering from drug abuse and alcohol abuse, you can help their endogenous production, but other times they're going to need the prescription for bioidentical testosterone cream. Okay, our last case here, Chris. This was a younger gentleman. He was in his 20s, and this is his natural testosterone level without supplementation, 130.7. So that's great. That's natural and normal for a teenager or someone in their 20s to have testosterone that high, whereas the total estrogen is 12.2. So this is a very good ratio to have. This particular gentleman had symptoms of acne and hair loss, which can be the result of overproduction of DHT from the testosterone. That's one possible explanation. And I just wanted to show you that younger folks tend to have higher hormones, and also athletes tend to have higher hormones on these tests. So that's about all the cases I have for you. And we're going to bring Dr. Willer back here and talk with you about a couple other tests.
Okay, so this is Frank, and it says Frank, but it's not Frank. It's actually Chris. And it says that his age is 22, but it's not actually 22. He's actually 60. So a little typo there. Anyways, so Chris here, I'm just going to go through this testosterone metabolized profile. Now, this is a serum profile. It's relatively new. Dr. Wright has been kind of, lecturing about male health for several years now and following the research, and it's all pretty much saying, and I've been doing a lot of research too as well. We're doing that creatine study to see how much, how DHT is increased with creatine, but also looking at how it's metabolized as well into things like 3-beta-adiol and 5-alpha-androstenedione, 3-alpha-17-beta-diol. I guess you could also call it 3-alpha-adiol for short. So I'm just going to go through each of these and kind of just talk about them briefly. So androstenedione. Androstenedione is a prohormone to testosterone and estrogen, like I said. And now some doctors will want to measure this before they begin testosterone replacement therapy, or whatever endogenous therapy they're looking at, because if androstenedione is elevated and we give testosterone or increased testosterone, it's more likely that androstenedione is going to be pushed into aromatizing to estrogen. Now, in this patient, the androstenedione was low, so that would not be a concern. But what if it was high? We would, definitely consider giving something like chrysin, putting something like chrysin in the cream that they apply. And so the 50 to 100 milligrams per day cream, you can get that, you're applying that to the perianal mucosa, so, you can actually get 25 milligrams per 0.1 mil, so you just get a very concentrated dose, and then you would have them, a compounding pharmacist, add a little bit of chrysin to that, and that would decrease the chance that it's going to be aromatized, or that there's going to be aromatization of the androstenedione. And then testosterone, we have that in here. This is total testosterone. The reason that is in there because we're going to compare it to the 5-alpha dihydrotestosterone, which is the next hormone. 5-alpha dihydrotestosterone is, like I said, the most potent androgen, 4 times as potent as testosterone. Now, when we look at the testosterone to DHT level, of course, testosterone is kind of like mid-range. If we just look at it, 5.6, and the DHT is high, 2.16. Now, this person who is 60 years old is applying a cream, a perianal to the perianal mucosa, and it looks like they have relatively high 5-alpha reductase activity. So we might also be looking at different 5-alpha reductase inhibitors just based on that. Because the testosterone and DHT level is low. So when that's low, that's more 5-alpha reductase activity can be inferred. So coming down to the 5-alpha androstenedione 3-beta-17 beta-diol, that is at the high end of normal. It's almost out of the range there. And the reason that is probably so high is because the reason it's high is because DHT is also high, and so DHT is being converted to the 3-beta adiol there. And now we can look at the 3-beta adiol to DHT. That should be not DHR but DHT ratio. The 3-beta adiol to DHT ratio is headed towards the low. It's the low end of normal, right? The more 3-beta adiol is an estrogen receptor, activates estrogen receptor beta. So it's an androgen that behaves like an estrogen, and estrogen receptor beta, is active in women. Estriol will activate estrogen receptor beta, and we see in postmenopausal women that having estriol greater than estrone plus estradiol, that can be a decreased cancer risk for breast cancer and other cancers. Now, we want to activate estrogen receptor beta and cause differentiation of tissues. But then we come down to our next metabolite, and that's the 5-alpha enostane 3-alpha 17-beta diol, also known as 3-alpha adiol, and that will interconvert with DHT back and forth pretty readily. So really we want to add DHT plus the 3-alpha adiol, and so those are both high. So we would be looking at why DHT seems to be getting stuck, because the testosterone is in normal range, so that we're really seeing a lot of 5-alpha reductase activity, but not a lot of the enzyme that converts DHT to 3-beta adiol is 3-beta HSD. There's also 17-beta HSD involved there, and 5-alpha reductase is also involved. But so it looks like probably the limiting factors here are the 3-beta HSD and the 17-beta HSD, and heavy metals will decrease that enzyme's ability to function, like cadmium. So we could look at heavy metal toxicity, and also PCBs will also decrease that enzyme's ability to produce that enzyme's ability to function. So this is an older patient. He could have been exposed to PCBs, so we could look at occupational or other exposures. And there's a number of treatments out there that look like they could be beneficial. Things. And by the way, PCBs and cadmium are linked to increased prostate cancer risk. So, and minerals that seem to reverse that and are linked to decreased prostate cancer risk are zinc, garlic, selenium. Okay, well, zinc and selenium were the two I was trying to think of there. Zinc and selenium, and selenium will increase glutathione levels, lipoic acid, vitamin E. All those seem to be beneficial and would probably be helpful in this patient. So while we might want to look at zinc especially first, and cadmium being too high and zinc being too low, because zinc will also help modulate 5-alpha reductase, which seems to be a little over the top. And then we could also look at GLA and saw palmetto potentially as well. Here's another case. This is Matt Smith here, and he is a younger man, a 19-year-old, and we're seeing basically low 3-beta adiol, which is a little bit surprising. So, again, we want to look at heavy metals and zinc deficiency, and maybe potentially, in his case, maybe stress could be, cortisol may be related to that. So, or there could be some, yeah. So in his case, we're seeing kind of a low DHT, or midline DHT. So his DHT is not too high, but his 3-beta adiol is too low. So that's a little bit concerning in a younger man. And then his androstenedione is headed towards the lower end. So it could just be some general depletion for him, and yeah. But yeah, we're going to be discussing this more. The research, this is a newer test, so we're going to be looking at it more next month, and along with some more case studies from Dr. Sherman. And so I should have more information for you. I have a whole, set of slides that I'm putting together on the 3-beta adiol, give you some more ideas for treatment. But if anybody's interested, any doctors are interested in having their testosterone metabolites tested in serum, we do have that available currently to physicians for free, so they can try out this new test. And if you have any questions, please just send me an email or give us a call. 425-271-8689 is the phone number for the lab. And I thank everybody for joining us today. You can sign up for webinars on our website. Thank you. And here's previous previous webinars that we have available right now. Kind of going through hormone testing, mostly for women, but there is one on there specific for men, andropause. And then also Dr. Larson did a really good bioidentical hormone therapies case study series, and that's also available on our website.